Good morning, good afternoon, and welcome everyone to today's webinar, Chaplaincy and Mental Health, Utilizing Clinical Expertise with Kjirstin Almos. I'm Andrew Andresco with Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio-visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of that same control panel. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a brief Q&A session at the end of today's presentation. I'd like to draw your attention to some upcoming webinars we've got. We've got one this Friday with Dr. Selena Carter on the Reflection Room, creating a space to pause, reflect, and share. There's part 3 of this mental health chaplaincy series, and that's going to be held on Wednesday, February 7th with Rachel Daly. And then lastly, on February 28th, we have a panel with Dr. Tarby, Dr. Choknoff, and Dr. Rosa, Research and Practical Tips for Palliative Care Clinicians. You can go to our website for all registration. I'll also be adding those registration links into the chat once Kjirstin gets started. I'd like to also draw your attention to Kjirstin had a resource handout that I've uploaded to the control panel. You can access that from your control panel. I'll also be putting the bit.ly link into the chat, and you can download it from our website from there. And with that, I'd like to introduce Csaba Szilagyi, Director of Transforming Chaplaincy.
Thank you, Andy. And I just want to briefly welcome Kjirstin and say thank you for doing part 2 to this series about mental health and chaplaincy. And we're excited to have this webinar as well as have all 3 parts available on our YouTube channel as an ongoing resource for chaplains. Currently, Kjirstin is a staff chaplain with Grace Hospice in Minneapolis, and she has extensive chaplaincy experience in pediatrics, palliative care, behavioral health, and ethics. And so thank you again for being here, and I'll turn this over to you.
Thank you so much, Csaba. It's really great to be back to continue this webinar series of chaplaincy and mental health, and to focus today on utilizing clinical expertise. As both Andy and Csaba just mentioned, this is the second of 3 webinars using an evidence-based approach to chaplaincy and mental health. My colleague Rachel Daly and I presented the first webinar back in October, and it is currently available on the YouTube page for Transforming Chaplaincy. And Rachel will conclude the series in 2 weeks from today when she presents Chaplaincy and Mental Health, Empowering Chaplains for Integration. We chose to use an evidence-based care approach because we have found that many chaplains feel like they're ill-equipped to care for mental health needs. We thought this would be a helpful way to bolster confidence and competence in caring for mental health. Evidence-based care is an approach to care that utilizes 3 components to help practitioners formulate their care. Our first webinar focused on the first component, which is the best available data or evidence. We presented an expansive literature review that looked at many topics related to chaplaincy and mental health. If you want to see the studies that we looked at and all the different things that we explored, I really encourage you to watch the recording of that webinar. But I am going to briefly review the 3 conclusions we drew from that review. Our first conclusion was that chaplains are caring for mental health in their work, no matter their setting. The data shows that mental health needs are really common among the general population, and they become even more common in all of the typical populations that chaplains are caring for. Therefore, chaplains should be prepared to address a mental health need in each encounter they have with a care recipient, whether or not they would expect it to occur. Our next conclusion was about the complex relationship between religion and spirituality and mental health. There was a tremendous amount of data that showed that religion and spirituality has a positive impact on mental health. However, we also found data that showed that religion and spirituality can complicate the experience of mental health or even have a negative impact. Now, since chaplains are the practitioners that care for religious and spiritual needs, they are inherently engaging with this complex relationship. Chaplains therefore have to be able to navigate this well in order to prevent potential harm to their care recipients. Our final conclusion was that chaplain care for mental health likely requires specific competence and training in mental health. Unfortunately, though, currently this competence is not a normative aspect of chaplaincy training or education. All chaplains, therefore, need to develop specific mental health competence in order to care for mental health effectively and safely. So that's the first component of evidence-based care. There are also, though, two additional components that are just as important to engage in this care approach. We will be looking at those two today. The first is clinical expertise, and then we will look at the individual patient or care recipient. We turn now to chaplain clinical expertise. Now, before we can talk about how we can bring chaplain clinical expertise into mental health specifically, we have to first have a good grasp of what chaplain clinical expertise in a more general sense is. Now, the challenge of this is there isn't really a universally agreed upon understanding or definition of what chaplain's clinical expertise is. In order for us to be able to have a conversation about this today, I am going to present a definition that is intended to be inclusive. It therefore might be a little bit simpler, so please let me state right now, I am not intending this to cover every potential skill that a chaplain has or uses in their work. The definition I'm going to use comes from the 2022 book, Chaplaincy and Spiritual Care in the 21st Century. This was edited by Wendy Kadge and Shelley Rambo. And you can see that it's a recent publication that brings together many different perspectives from seminary faculty, CPE educators, and chaplains. These individuals represent a wide range of religious and spiritual background and institutional settings. It therefore gives a pretty broad perspective and hopefully should be inclusive to all chaplains who are watching this, no matter your institutional setting. In the book, they identify three main areas of competence that chaplains should have. I will be focusing on two today. The first is meaning making. Meaning making is the ability of chaplains to interpret situations and experiences by appealing to systems of meaning that align with spiritual and religious traditions. Now, this is a larger area of competence that has many additional skills within it. For example, chaplains should be able to listen for the values and beliefs that frame the meaning in their care seekers' lives, and they should be able to support care seekers when there are times where they have to reframe and reconstruct meaning, such as when there are times of transition or challenge. The other main area of competence they identify is interpersonal competence, which is a set of practices that enable chaplains to show up fully, to listen, and to respond to the needs of others without imposition of the chaplain self. Similarly, there are many skills that go along with this competence, such as being able to build trust, embody empathy, and differentiate between the self and the other. Chaplains should also be able to create a spiritual interconnectedness that allows them to establish a spiritual trust and addresses the spiritual dimensions of relationality. So now, if this is our general chaplain clinical expertise, we can now look at how do we bring this into mental health. Well, the first thing to note when looking at chaplain clinical expertise is that much of this spiritual care is oriented to pretty high levels of cognitive functioning on the part of the care recipient. Let's just look at meaning making, for example. In order for someone to engage in meaning making, the care recipient has to be able to articulate what they're going through right now, identify emotions that they may be having, be able to speak somewhat to values or belief systems that can be informing their current situation, so on and so on and so on. Even if a chaplain is helping to facilitate this reflection and identify these things, the care recipient still has to be able to go along with the chaplain in that. Now, the challenge when we come to mental health is that mental health can impact cognitive functioning in many different ways. So suddenly for chaplains, the expertise that we bring to most forms of care that is effective suddenly isn't working as well, and chaplains can be feeling lost or unsure on how to bring spiritual care to people with mental health needs. Now, the good news is all is not lost. It's not that these individuals just can't get spiritual care. Rather, by adapting our assessment skills and approaches to accommodate and be sensitive to mental health, chaplains can successfully utilize their clinical expertise to care for mental health. Now, why am I saying assessment? The reason is assessment informs almost every aspect of spiritual care, and assessment is the means to engaging chaplain clinical expertise. Now, I should pause here and say that when I'm talking about assessment right now, I am not referring to a particular model like FICA or HOPE or an SSTAT. I am talking about the larger skill set of assessment that goes on behind those models. So this is the ability of the chaplain to observe relevant data and interpret and apply it in a meaningful way for the provision of spiritual care. When we take a step back and look at that larger skill set, we can quickly see how chaplains are using assessment in almost every aspect of their spiritual care. We are assessing what's happening before we get to a care encounter if we know it's coming, from the minute we get there to see what's going on for the care recipient, what their needs and experiences are right now. We're assessing ourselves and how we're responding to the situation and what are the interventions we're applying and why. How is that person responding to it? What other resources might be appropriate? So on and so on and so on. It is through all of this assessment that we are able to utilize our clinical expertise to provide meaningful spiritual care for people. Therefore, if our assessment approaches are not inclusive of mental health and they are not able to account for it, then we can never really give these individuals the benefit of our clinical expertise and care. Now, similarly, assessment is a really big topic. It's similar to clinical expertise in that way. There are many different models, as I've already indicated. There's also many different perspectives, understandings, and even research about spiritual assessment. So in order for us to have a conversation today about how we can utilize our assessment to care for mental health, I'm going to use a very simple, but I would argue very common way to think of assessment, which is the phrase, I meet them where they're at. I would guess that most chaplains have used this phrase at least once in their career, and it's honestly the place where a lot of us start. Now, typically, we don't really think of this as assessment, but this is functionally an assessment statement. It's really hard to meet people where they're at and provide them the care they need if we haven't figured out where that is yet and have gotten ourselves to that place too. Now, typically when chaplains are using this phrase, we mean this as meeting someone where they're at emotionally and spiritually. Let's just look at a brief example to get a baseline for what this typically looks like. So let's just look at a brief case study. You are the chaplain on call at a healthcare institution, and you get a call that someone has died and they want you to come support the family, and you really have no more information. You get to the bedside, you see that it's an elderly woman who has died, and there's a number of middle-aged adults around the bedside. They are tearful, but the atmosphere is generally calm, and they're speaking quietly with each other. After you introduce yourself and express your initial condolences, the family says to you, oh, thank you, chaplain, for coming. You know, we are sad. We're going to miss mom a lot, but we also know that she was in a lot of pain these last few years and she just wasn't having a very good quality of life. She was blessed with such a good life overall, and we're so grateful that we've had her. She was such a wonderful mother. But she's in a better place now, and she's with our dad, and we're just happy that she's back with him again, and she's not in pain anymore. So this is really just the beginning of the encounter. All you've really done as the chaplain so far is introduced yourself. But already we've been able to learn a lot and assess where this family is at emotionally and spiritually. So we can see emotionally they're expressing a lot of sadness over the loss of their mother, which is appropriate that she's died now. They're also expressing relief, though. They saw that she was in pain and uncomfortable, and they're feeling relief that she's no longer in that place. Even though these can be really big emotions, especially grief and sadness, they appear to be coping pretty well at this point. We also learned quite a lot about their spiritual beliefs, even though they never identified a particular religious tradition. For example, they believe in an afterlife, and that afterlife is good. It's a better place. They believe in reunion with their deceased loved ones in the afterlife. They're saying that now she's back with their dad, which is a good thing. They also expressed a spiritual value of gratitude for their mother and her life. So if you're the chaplain in this situation, you can meet them in these spaces and start to use your clinical expertise in a variety of ways to provide care to this family. So this is how we use this phrase, meeting people where they're at, more generally. If we want to bring this into the dimension of mental health, we have to add one more layer, which is that chaplains must also meet people where they are at cognitively. Meeting someone cognitively means being aware of a care recipient's current cognitive state, how it may be impacting the spiritual care encounter overall, and how to adapt chaplaincy care accordingly. Now, there's a lot to say about how we meet people cognitively, but perhaps the most important point about this is that it requires adaptation on the part of the chaplain. Now, this adaptation and meeting people is already pretty normative for us. We do this a lot when we're meeting people spiritually and emotionally, many times without even being aware of what we're doing. For example, if we think back to this elderly woman who died, if, say, one family member was not coping well and was very tearful and very sad, as the chaplain, you would adapt to what that person needed, even if the other people were in a different place. We have to do similar adaptation when we meet people cognitively, but it can add more aspects and layers to it, in part because cognitively is a really broad term. When we're assessing cognitive states, we might be looking to things like people's reasoning, perception, memory, attention, judgment, and more. Now, the good news is we don't have to suddenly become clinical psychologists or a psychiatrist. We don't need to get bogged down in the technicalities of all of these pieces. Rather, as chaplains, we need to focus on the experience the individual is having from within their cognitive state, because that's where our care is meeting them at. Now, similarly to any other type of care we're providing, it is really important to keep the focus on where someone is at of the specific encounter and adapt to that person in the moment. Now, that again is true with most care we provide, but it's worth noting it because in mental health, the cognitive states can be a bit more fluid, and adaptation might have to happen with a bit more flexibility. So now to contrast, let's look at a different case study that is going to look at how we do meet people emotionally, spiritually, and cognitively. And this case study is going to involve the symptom of psychosis. And this comes from my care. This story happened when I was working in a hospital that had inpatient behavioral health. I was actually on the floor and in the common room talking to one patient. And as I was doing that, I noticed a different patient was looking at me from across the room. As I finished with my first patient, I kind of wasn't surprised that then this other person was looking at me, came over to talk to me. And we had the following conversation. Said, "Can I ask you something?" And I said, "Sure." And he asked me, "Are you an alien?" And I'll admit I was really surprised because I was not expecting that to be his question. So I kind of stammered back, I don't think I am. And he looked relieved to hear that. And I asked, "Are you?" And he reassured me, no, I'm not. But you have to be careful because aliens are everywhere. So again, this is really just the beginning, but let's pause here to assess where he is at. So emotionally, we're seeing some potential fear and anxiety. He was checking me out to make sure that I was this safe person and that I wasn't an alien. So he's expressing some uncertainty about his environment. Thus far, we haven't learned a lot about him spiritually, but even in these few short sentences, we have learned a lot about where he is at cognitively. First, we've learned that he is experiencing delusions about aliens. And in these delusions, aliens are real. That's not really a question for him at this point. Furthermore, aliens are not discernible by appearances alone. He had to ask me if I was an alien. And the good news was he took my answer. He seemed to trust when I said that I actually wasn't. And we know that aliens are concerning. He clearly indicated you have to be careful about them. It's not clear exactly what the concern is, but that there's something not good about them. So recognizing all of this, I can now engage my clinical expertise to care for him, thinking of the competence of meaning making. Like I said, for him, aliens are real. That's not the question at hand. So I have to meet him in this worldview that aliens are real and that they are concerning. I can then also engage my interpersonal competence and see that his emotional state makes a lot of sense. And I can then use that skill of empathy to respond to him. So what I did say back to him is, that sounds really scary to me. Can I ask you, do you feel safe here? And he nodded and said, yeah, I do. And then he smiled at me and he walked away. So presumably he had gotten what he needed, was just the reassurance that the place that he was in was safe. And I was able to do that by meeting him exactly where he was in that moment. Now this raises a kind of obvious question that follows all of that, which is how do chaplains build competence in meeting people cognitively? And there's a few ways to do it. The first is increasing mental health knowledge and basic literacy. As I said, we don't need to suddenly become a clinical psychologist, but we do need to have some basic framework and understanding so that if a diagnosis is used, we have some understanding of what that is or what symptoms there might be, and even having some basic understanding of the larger mental health care system. Equally important, perhaps more important though, chaplains also need to have an understanding of what the experiences are like. Again, that's where we come in to care for people. So we have to consult first-person narratives, such as memoirs or videos where people share their experiences. That can help us build that interpersonal competence and engage the compassion that we have in so much of the rest of our care. Now, at the end of today's webinar, as Andy already talked about, we have a resource that my colleague Rachel and I developed as a tool to help chaplains build their competence. And these are 2 of our 4 strategies on there. So in that resource, if you want to find some great ways just to start building your competence in mental health and hearing these first-person narratives, we give you a lot of resources and places to start. And the good news is about those resources is most of them are free and you can access them as you have time and energy to do so. Now, the third way that chaplains can build competence in meeting people cognitively is something we have a little less control over, which is that continued experience in practice. In some ways, this comes back to CPE, where we talk about action, reflection, action. We build our abilities and competence in spiritual care by just continuing to do it and continuing to grow. Now, if you work somewhere that has dedicated behavioral health resources and care, you might be able to grow in that with some regularity. If you don't work in an institution that has that, it will be a little bit more haphazard when you're able to care for mental health. One thing I will note, though, is that if you increase your knowledge and awareness of mental health needs, you will start to see it more no matter what type of institution you work in. So that concludes what we need to say about the component of evidence-based care of chaplain clinical expertise. We now turn to the third component, which is addressing the needs of the individual patient or care recipient. Now, since we're looking at chaplains in this, honestly, there's not a lot we really have to say about it. Chaplaincy is already really well suited to addressing the particular nuances of the individual care recipient. Chaplains already have a high level of awareness that each individual person and their situation is so influenced and informed by the particularities of the individual. Our work is already then very geared towards meeting people and what they, in their particular situation and circumstances. Therefore, I'm not going to continue to go through all of that when we know that so well. Instead, I'm going to use the rest of my time today to present a number of case studies of caring for mental health needs, and especially some symptoms that sometimes are more complex on how to deal with. This will show us how chaplains have engaged clinical expertise and evidence-based care to provide effective care for people with mental health needs. This first case study looks at religious psychosis, and this is an example that comes from my care. This was a setting where I was in a hospital with inpatient behavioral health. A patient attended a spirituality group I provided, and he asked me later to come meet with him for an individual visit. As I got there, he started telling me about how he felt like something evil was attacking him and that it was really scary being in the hospital right now. He was in quite a lot of distress. And in part because as he's feeling something evil attack him, he's also saying, I can't feel God right now. Now, the visit had been going on for a while, and he had been sharing these heavier things with me. When he then said, can I tell you something that I've been scared to tell the staff? I think they would just call this a Messiah complex. And I said, yes, you can if you're comfortable. And, he looked a little hesitant still, but then he whispered to me, I'm Jesus. So again, let's just pause here to see where we're at already emotionally, spiritually, and cognitively. We see emotionally that he is experiencing distress over these spiritual concerns and he doesn't feel safe. So if we look at meeting him spiritually, we see that he's indicating a Christian worldview, particularly by his last statement of believing or of Jesus. But he's having a lot of spiritual distress. He has this fear that God has abandoned him. And again, he's also having this feeling that an evil spirit is attacking him right now. Now, cognitively, up until that last statement, I hadn't noticed anything that would be overly noteworthy. But then this certainly changes where he's at right now, where he tells me that he believes he is Jesus. So he appears to be having religious delusions. He also has a really interesting insight right now. He is aware that others will likely not believe him, right? He said the staff probably will just tell him it's this Messiah complex or tell him this is just a symptom. So it's worth noting here that he's not really asking me or looking for me to affirm that he is Jesus. He was looking more for someone to trust, that he could tell this to, and who wouldn't immediately be dismissive of him. So again, this is a moment I can engage my clinical expertise. In his worldview, he is Jesus. And if we see that he is Jesus and he is feeling like God has abandoned him and something evil is attacking him, it helps give even more insight to the level of spiritual distress that he is experiencing. So in my response to him, I engaged in that meaning making from this perspective, and I validated those concerns and challenges that he was experiencing in that moment. I was able then to engage in reflection around sources of hope and how God was present with him in the past. And this all appeared to be effective. He started moving to a place where he was calmer. And prayer was an important ritual of meaning for him. So I closed with prayer and I focused it more on God's light and love to, again, return him back to the sources of strength and hope rather than being focusing on this evil that he was feeling. And at the end, he expressed that this was helpful for him and helped him feel calmer. So now let's contrast that case study with religious psychosis with a different story. And this comes from a colleague of mine. She was similarly working in an institution that had inpatient behavioral health, and a patient requested to have a visit with her. As she gets in the room, she immediately sees that this patient is hyperverbal, meaning that this patient is talking very rapidly, very quickly. For the first long while, my colleague really isn't able to get a word in. And what this patient is sharing about is how she is Jesus. And she starts sharing all these different ways that she realized that she was Jesus and all these signs that she saw God putting out to her to make sure that she knew this. For example, some of them was kind of a form of numerology, that she saw these different numbers and different patterns. So it informed her that, yes, indeed, she was Jesus. And as she continues in this, she starts to move on to how she is going to heal people because she's Jesus. And not only is she going to heal people, but she is going to heal all the diseases in the world. So again, let's pause here and let's see where she is at emotionally, spiritually, and cognitively. And I'm going to start here with the cognitively. So she is likely experiencing a form of mania, and there's a number of signs here that are indicating that. For example, she's having grandiose thoughts. She's going to cure or she's going to heal people in the first place, and she's going to heal all the diseases in the world. That's a pretty grandiose way to think about it. As I've said, she's got hyperverbal speech, and she's having disorganized thoughts. As she's saying all these things, the thoughts aren't always connected to each other, or she's jumping around from topic to topic. And again, we see a religious delusion in which she is identifying as Jesus. Now, it's interesting to note where she's at emotionally. She is in very good spirits throughout this visit. In fact, she's really eager that she gets to share about this with someone, about how she is Jesus and what she gets to do with that. If we look at her spiritually, again, she's indicating she's in a Christian framework, and she feels this really personal connection to a God who communicates directly with her. But importantly, there's also this value of compassion and helping others that's coming through. It's really important to her to do this healing for others. So again, my colleague engaged her clinical expertise and saw that this value that was coming through was a way to engage in meaning making with her. Now, similar to the Jesus I met, this person wasn't really asking to see if my colleague agreed with her that she was Jesus. This was already within her worldview. So my colleague extended presence and active listening with her. Many times when people are hyperverbal, it can be a lot, and many staff people may not want to take the time to continue to listen to someone. So my colleague did stay and give her that additional active listening and presence throughout that. She also affirmed her desire for helping others and the value of compassion that was really starting to come through as she shared about this healing for others. And as she was able to do that, they were able together to talk about the experience of suffering, and my colleague could empathize with this patient of suffering. She also closed with a prayer that was focused on healing and compassion for others in the world. And all of this, again, appeared to be very helpful for this patient and affirming to her. The next case study involves dementia and suicidality. This also comes from a colleague, but this occurred on a medical surgical unit in a hospital. The call came in to the spiritual care team that this patient wanted a chaplain visit, and there was really no more information given. My colleague arrives to the patient's room, and she sees that the patient herself is asleep, and her daughter is at the bedside. So the visit begins by engaging with the daughter. And the daughter starts to share about how while they've been in the hospital, her mother, who has dementia and who the daughter has been caring for a long time, is starting to see really scary things that aren't there. And that when this is happening, her mom is asking her, like, what's happening? And the daughter doesn't know what to say back to her or how to help her in these moments. The daughter starts to reflect on caregiving for her mom and how she's been caring for her for years, but this symptom of seeing scary things is new to her. And she starts to reflect on what this symptom could mean and her larger role of caregiving. And this new symptom kind of forces her to realize her mom will continue to decline and at some point will die. And when she starts to think about that, the daughter says, I'm scared of what I will do when my mom dies, because if I do what I'll want to do, I won't be with her. So pausing here, we have two people who we need to meet in this care encounter. Now, so far, the patient has primarily been asleep in the bed. And so what we're learning is what we're hearing from the daughter, which is that lately she's been having a tremendous amount of fear and anxiety over these things that she's seeing, and that in these moments, she's seeking support from her daughter. The daughter tells my colleague in the visit that they are Catholic, and cognitively, we see again these changes in perception, and that not just that this patient is seeing things, but she's seeing things that are very, very scary to her. Now, the challenge with this symptom is that it is occurring in the hospital, and the patient has dementia. So could this be a new ongoing symptom of dementia? It could. It also might just be caused by delirium of being in this disorienting environment of the hospital. And at this moment, it's hard to say to the daughter which one it might be. Now, additionally, we have another care recipient in this encounter, which is the daughter. And she emotionally is also expressing a lot of distress over how to support her mother and these new symptoms. She also expresses being overwhelmed by the caregiving. She's kind of alone in this, and of course, caregiving is a lot of work. She then also ultimately gets to anticipatory grief of recognizing that at some point her mother will die and what that will mean for her. I'm going to skip to cognitively first before we go to spiritually, because at the end, she starts speaking euphemistically about suicide. And she's indicating a potential future suicidality, but not a current one right now. She's afraid of what she might do in the future. And this fear is coming from where she's at spiritually. So the daughter identifies as Catholic, and she's implying that she believes her mother will go to heaven. And she also has this belief that would align with the Catholic tradition that suicide means not going to heaven. Now, so she's expressing distress that by potentially becoming suicidal or dying by suicide, she could maybe not end up with her mother, which is giving her quite a lot of distress in this moment. So to meet her in this, my colleague did a variety of interventions to support the daughter. First off, she acknowledged the responsibility of caregiving, and she facilitated a lot of meaning making around this current decline and how that relates back to this role of caregiving. She also helped the daughter process the anticipatory grief that comes along with this. And just because caregiving will continue until that ultimate decline, she provided a lot of education and affirmation for the overall self-care that this daughter needs. Now, As this part of the care encounter was happening, the patient did wake up and she started to see these frightening things. And the daughter again appeared distressed of not knowing how to help her mother. So my colleague modeled a response of how to support someone in this. She provided a very calm presence and reassurances to the patient of her safety so that that would help the daughter know what to do if this symptom continues into the future. The final case study I'm going to present will look at dementia. And this comes from my work in hospice. So this is a patient I got to know over a length of time. And this is a composite of many different visits that I had. She was very open with pretty much everyone on the care team, and especially me, that she was ready to die. But this was actually distressing for her because she didn't know why God just wouldn't let her die yet. She was more than ready. She was waiting for it to happen. And she kept saying, maybe God is angry at me, and that's why he's not taking me home yet. Now, when I would be in her room, typically the TV would be on or there'd be other things happening. And so maybe a commercial would come on with a train. And so she would then say, oh, look, a train. I once rode in a train. And she'd continue on that for a little bit and then suddenly say, you know, I gave my life to God as a young woman. Did he forget about me? Is that why I'm still living when I'm not supposed to be? Oh, and then, oh yeah, the staff here is terrible. And here are all the things that they do to me that I don't like. So again, thinking about where she is at emotionally, spiritually, and cognitively. Emotionally, this really varies depending on the topic that she's bringing up. We can kind of use the word almost labile for her, that if she was talking about, you know, God has abandoned her, she would be very sad. If suddenly she starts talking about a good memory, she gets very happy. Now, that being said, she was pretty consistently sad and frustrated with this desire to die not being fulfilled and this concern about what that meant for her relationship with God. Spiritually, she is indicating this lifelong faith, right? She said she gave her life to God as a young woman, and she is frequently indicating that she is ready to die and be in the afterlife. And she's got this fear of kind of what's happening and why isn't that coming to be? And her most common reflection was maybe God was angry with her, or maybe even God's not going to take her to heaven. So now cognitively, we can see that the dementia is really impacting her reasoning and her attention span. Especially at the attention span, as you could see, it was very normal in the conversation for her to just jump from one thing to another. And she couldn't focus on any one of those pieces for very long. She was then therefore having kind of disorganized thoughts as she would jump through all of them. And it's worth noting that she potentially had some depression because she had these frequently low moods, and she really ruminated on this spiritual distress. While she shared this with me, certainly as her chaplain, she actually shared it with pretty much every member of the care team. Now, it's not so important necessarily to identify, was this purely coming out of dementia or was there depression additionally? But simply to recognize that she did consistently experience low moods and have these higher levels of spiritual distress. Now, meeting her in all of this could be quite tricky because I kind of never knew where she was going to be at, even from moment to moment. So it was always kind of a trial and error. Whatever feelings she was bringing up or experiences or questioning, I would validate them. And because she was able to articulate these pretty clear levels of distress and experiences, I always attempted to engage in reflection as much as possible each visit. And sometimes we were able to do so. And then I could visit a few days later and she suddenly couldn't. It just wasn't really within her capacity at that particular visit. Now, it was, like I said, a trial and error. So each time I tried to give the opportunity to do that if she was able. And if that day it just wasn't, then it was okay to step away from that intervention. Sometimes I would also try to provide gentle redirection if she had been sharing with a bit more clarity about an experience she was going through, if she then suddenly got distracted by something else. Now, if the redirection didn't quite work as I would have hoped, I would then kind of continue with her where she was at because it seemed like that day maybe just couldn't do that. And many times I also helped return her to her known sources of comfort and strength, which was like sources of scripture within her faith tradition. So in conclusion, we have covered quite a lot of looking at evidence-based care between the previous webinar and this webinar. I hope that this can be a start to bolstering your confidence in caring for mental health, because as we've seen from the evidence, you are going to care for it if you are working as a chaplain or spiritual care provider. I've already touched briefly on this resource that my colleague Rachel and I have developed, but I'm going to talk about just a little bit more fully. We've identified 4 strategies to help chaplains grow in this work. The first 2 I've already talked about, of mental health literacy and learning from first-person accounts. However, there are 2 additional strategies for us to look at and engage. The first one would be reflection on our stigma, experiences, and values. We can be intentional in our professional work of including mental health, but if we don't have, or if we are experiencing personal stigma, that is still going to impact our professional care. We therefore need to engage in what could be challenging reflection so that we can work through stigma or experiences that we have internalized about mental health. The last educational strategy that we give are theological and faith resources from a variety of faith traditions. These can be helpful resources from your own religious background, or if you're caring for someone who's from a particular faith tradition. This can be a great resource to go to help you in that care. That's going to be available in the chat today, and if you register for the webinar, it'll be sent to you in the follow-up email. It's also available on the Transforming Chaplaincy website. And again, all of these educational strategies are intended to be very accessible. We want to help chaplains grow in this and care for this population. So hopefully this can be a great springboard for you as you do that. Rachel and I are very happy to be reached out to and to support people in any way we can as they care for mental health. I highly encourage you to tune into Rachel's webinar in 2 weeks, where she'll take how we're looking at this evidence-based care for the individual and how we think about mental health and chaplaincy at a more systematic level to make sure that we're providing care for all people who need it. I'm happy to use the rest of this time today to have further conversation and have Q&A about chaplaincy and mental health.
Thank you, Kjirstin, for this wonderful presentation. And I think as we were chatting before the meeting, it's such an excellent example of integrating evidence and practice and your expertise and case examples and how those threads can be weaved together in our chaplaincy practice. Thank you for being available for questions, and I want to encourage people who are on the webinar to use the question box for your questions. And I'm gonna go and check if there are any questions coming in. People are saying thank you. A question, it sounds like you utilize a model of meeting patients mentally, emotionally, and spiritually along with other models of assessment. Or does it stand as kind of as a standalone model for assessment? So I think maybe, you know, you very clearly, it was very helpful to have those domains after each case, and I think the person is wondering about, is it a standalone model of assessment or is it combined with other assessment models?
Yeah, and it's not actually, like I would say, the assessment approach that I use if I talk about the model. Rather, I was trying to think of a way of how do we talk about assessment that most chaplains can agree with and say aligns with their experience. I think you could use it close to a model. It certainly kind of has some of those pieces to it. It would be a little bit on the simpler side. And really what I kind of think I was doing more was breaking down the skill set of assessment of what you're actually looking at, what data is coming in to inform you in your care. So I think a lot of us would probably, after a number of years and experience, would move on to something that's got more meat to it, for lack of a better way to say it. But functionally, it's working within that framework in the background.
Thank you. There are further words of gratitude around using case studies, and There's a question around whether you could speak to chaplains doing an honest and thorough self-assessment of their own mental health and how that impacts, interferes, and informs their care for others. So the chaplain's mental health and how that may inform or interact with the care that they provide for others.
I think that if the implication of this is that someone has their own mental health condition, it can honestly be a great source right there of a first-person narrative, right? That you have some insight into one mental illness and what those symptoms can feel like. Because it's one thing to say that someone who has schizophrenia has delusions or has hallucinations, but if you've actually experienced that, you have such a different insight into what that is. And I think this goes along with any other aspect of ourself, of how we have to differentiate, right? Every aspect of our lives informs us and our spiritual care in a variety of ways. And we have to know how to use that helpfully and where those boundaries are though too, because ultimately we're caring for someone else. That's kind of what's identified in the interpersonal competence. And I think it's a lot of the work that we do in CPE, right? Learning how to say, when is it me? When is it the patient? And how do I walk that boundary well?
And as I think, and as even as the question said, it can be both as a resource as well as something to keep checking and how that may interfere or complicate some care encounters as well. Another a comment question regarding the case with the daughter and mother with dementia. And as you were thinking about that, she was experiencing delirium in an unfamiliar setting, can be spot on. However, another option for folks with dementia is seeing things and remembering or re-experiencing memories of trauma. And trauma has a big impact on mental health and can be ignored in this conversation. So what are your thoughts about the role of trauma, how trauma history or current trauma factors into these care situations?
Yeah, absolutely. That's an excellent point. And as someone who now works in hospice, I can say that's 100% true. That, with dementia, it is this permanent decline in someone's brain, right? It is a disease. And as the brain starts to decline and deteriorate, it can bring back experiences of trauma. And sometimes it's really hard because families maybe never knew if it was like a childhood trauma, their loved one never talked about it. And then suddenly it starts to come back or come out in these different ways. So yeah, that's an excellent point, that maybe what this person was experiencing was a trauma her daughter never knew about. So now this will impact the daughter's caregiving for her mother, because this might be ongoing then. Unfortunately, a disease like dementia doesn't get better. Some mental illnesses, we can get to a place of wellness, and that's one where we don't really get better from there as much as maybe we have better days. So again, like I said, we don't always have to parse out all the technicalities, but we kind of follow the person where they're at. So if this woman discharges home and this continues, then yeah, this says to us that certainly it's going to be ongoing. And then if, say, we somehow had a contact with the daughter at that point, she's in the home, she's back caregiving, that'd be a great time to work through trauma-informed care. And it would really look similar to what my colleague was doing. She was validating the fear, right? For that woman, whatever she is seeing, it's real and it's very scary. And so we have to start just from there, validating it. And we could coach the daughter on how to work from that trauma.
Thank you. There's another question and comment, again, reappreciating the case studies, and we could spend a lot of time unpacking and spending time on many different diagnoses. And this chaplain's perspective is that there generally in patient units, there are experiences of depression, anxiety, and more often than they have expected, personality disorders. So outside of providing good supportive pastoral support, as you have described and demonstrated, do you have any comments on providing support to persons with any of these specific conditions, diagnoses? And they were mentioning depression, anxiety, and personality disorders.
So it's a challenging question to ask because, as I've pointed out and hope that I could kind of show, is it is so individualistic. because no two people have the same form of depression. Different symptoms can pop up and still both be diagnosed as depression or anxiety. I would say that there's some adaptations we should be prepared for. So for example, depression or anxiety can kind of, if it's like more severe, maybe kind of lock people into a certain mental place. So for example, a common symptom of depression could be hopelessness. Everything is hopeful. And a symptom can be black and white thinking, which is really impacting reasoning. So if someone says to you everything is hopeless, we try to engage some reflection around, well, what does that mean? Where is that coming from? But if someone's got black and white thinking, it may just end up in a circle and it may not be able to come out. And that's a day where we may have to recognize that this might be the limitation of the disease today, that we're not going to be able to engage in that level of care. That doesn't mean it's permanent. If someone's getting care for their depression and they're getting better, then maybe in a couple days that's lessened and we can engage in that. But again, that's one example of what could be, and you could meet a number of depressed people who do not have that symptom.
Yeah.
So, like I said, it's hard to give a specific answer as much as I think building your competence so that you can start to see how these differences play themselves out. One thing I would encourage people to do, like I said, I'm a really big believer of those first-person narratives. I think that's where we're going to build up our spiritual care competence and really that praxis of it. Is if you're, say, listening to a YouTube like video of someone sharing their mental health story, just pause it at a random moment and stop there and think, if you were the chaplain, this person was sharing this with you, and this is just what happened, what would you be thinking? What would you be assessing? What would you think about doing? Kind of put yourself in that situation. It's kind of like a freebie. It's a free way to practice without having an actual care recipient in front of you.
Yeah. And I think that all just nicely ties together that idea of if you realize that these are the diagnoses that you most frequently encounter, to learn about the lived experiences of persons with that kind of showcases both the common themes and the diversity within the experience, kind of the wide range experiences, learning about the evidence and what kind of the clinical understanding of the condition as well, and then your expertise and seeking out maybe other chaplains who have some long experience and expertise in this area as well could be very helpful. We have another question, and somebody's wondering about whether you live in an area where death with dignity exists and voluntary stopping eating and drinking. I'm not familiar with the latter program. I'm not sure if the person who was typing the question could give us some more context. Because the question is, if so, how you have dealt with this possibility. So if you can have more clarification around those questions, unless you have a...
So personally, no, I've worked in a couple of different geographical areas and none of them have been areas that have death with dignity. I do work in areas where there is voluntary cessation of eating and drinking. I don't have a lot of personal experience with that. And again, I think that's really an issue of looking at the individual's situation. That's certainly a really complex topic. And I think that's a topic that for chaplains is going to personally probably push on a few things within us. It's emotionally really, really heavy. And again, I think it comes down to what is the particular situation? Why is that person choosing to die with dignity, to end their life? It's worth noting that in most states with death with dignity, there's a lot of qualifications around it. So multiple physicians have to say, for example, this person is going to die already. Is that what's informing their decision? Yeah. So I'm sorry, I can't.
Yeah, and thank you for the clarification about voluntary stopping eating and drinking is used by people with mild dementia. So I think that maybe connects back to the dementia care that you were describing, or diseases like ALS, where suffering is very extended.
Yeah, and it is something that's interesting. It can be written into advance directives. So sometimes people write that in their advance directive 15 years before they'd be at a point where that would even be a reasonable possibility. And it can become very complex of, well, you wrote that 15 years ago, but is this really what this person would want now? And again, it becomes very much what is the larger context and story of this person and their care.
Yeah. And relying maybe also in those situations, the expertise and assessments and bringing those together with other interprofessional colleagues in those situations, from the physician to the mental health practitioner to the chaplain, and having that team approach to these situations.
Yeah. And I think it's just maybe important to note, because what that is coming back to is suicide, of which there is a tremendous amount of stigma around, and we kind of touched on stigma in our first webinar, is to be really sensitive to that. Especially your interdisciplinary colleagues may struggle with some of that stigma too, and to really hear where is this person at. And, you know, it is functionally a level of suicide, but within suicidality, there is such a spectrum. So just to look at where is this on that spectrum.
I think that was the last question we had from the participants. Thank you again for your presentation and engaging these very important practical questions. And as one of the participants said, that, you know, we could talk about these topics for a very long time, and even go into the different conditions and the cases that you presented. But I really appreciated the breadth of the wide-ranging cases and assessment and role of the chaplain. And if you're interested, we do have the Chaplaincy and Mental Health Care newly established research network within Transforming Chaplaincy. So please send us an email if you are not yet part of that network and you're interested in joining, and we can send you the invitation to our online platform that we use for that network, where further discussions may take place. You can pick each other's brains around best practices approaches. We're gonna also upload these webinars as resources. So if you're interested, please email us and we'll send you invitation to that network. Again, thank you very much for being here today, and I look forward to part 3 of this webinar series in a few weeks. Thank you again. Bye-bye.
Thank you so much.